patients. We will cover, inshallah, the laboratory findings, its blood test, the radiological findings, histomorphometric findings, and we'll talk briefly for diagnosis. For lab, it is a simple blood test, and the result depends on the major cause of the disease, and we know what is our major cause, vitamin D deficiency. So when vitamin D is deficient, we will see the following. There will be great reduction of the inactive form, which is 25-hydroxyvitamin D. So the levels of calcium will be eventually low. Over time, the parathyroid hormone will compensate and may also develop to secondary hyperparathyroidism. Secondary hyperparathyroidism may also deteriorate the phosphate excretion, so also phosphate will be reduced. For radiology, it is chest X-ray, but generally in osteomalacia there will be decreased bone mineral density, but this is non-specific because also osteoporosis has low BMD. So we see two features in the radiology, plain X-ray. First is there will be changes in vertebral bodies. This is due to bone mineralization of the bodies, and it will give us a good fish appearance, which is a concavity of the bodies, as illustrated here. Also, this codfish vertebra may also cause spinal compression fracture, high risk of fracture. Milkman syndrome is a multiple bilateral and symmetrical loser zones all over the body. So we talked about the first thing, change in vertebral body. Second is loser zones, also known as pseudofractures. Pseudofractures are like a white band which appear as incomplete fracture. For rickets, there will be tibia bowing, irregular metaphasal fraying, and metaphasal cupping, as my colleague mentioned, and as illustrated here in the diagrams. Cupping and bowing. We're back to loser zones. Loser zones occur bilateral and symmetrical and perpendicular, means 90 degrees to the cortical margins of bones. Loser zones may appear on the scapula, on clavicle, metatarsal bones, and vertebral bodies, but most commonly seen on the femoral neck, on the medial shaft, below the lesser trochanter, as illustrated here. This is like a pseudofracture, but it's incomplete on the femoral neck. Yes, for histomorphometry, it is basically a bone biopsy doubled with tetracycline labeling, but it is not frequently performed in clinical practice because it is invasive and it is for rare bone diseases. Two characteristics for osteomalacia to be seen. First is the increased prolonged mineralization lag time, and second is the excess osteoid accumulation rate. In above, this is a normal bone. Below is the osteomalacia bone. We can notice here our orange stain. Orange stain here is the excess osteoid thickness, which is an mineralized bone. Other disorders can manifest one of these results. For example, widening of osteoid stems with high turnover can be seen in hyperthyroidism, hyperparathyroidism, and Paget disease, also with increased mineral apposition rate. Mineral apposition rate is the rate at which the bone is mineralized. So, but in osteomalacia we have low mineral apposition rate, so we can rule out. Yes, briefly for diagnosis. Diagnosis might be difficult, and this disease is often diagnosed delayed when the disease is progressive. But it can be suspected with bone pain associated with the disorders that we mentioned before, like malabsorption, celiac disease, chronic hepatic kidney disease, and gastric bypass surgery. For gold standard and research purposes, the most accurate way to diagnose osteomalacia is by trans-iliac crest bone biopsy with tetracycline labeling and histomorphometry. Clinical signs and symptoms and radiology and laboratory, all these can help us to diagnose osteomalacia, as these symptoms say here. These are the references, and we'll continue with the management with Ahmed.